Okay, perfect. So let's dive right in with webinar 3 of 3. So we'll start out, of course, with the disclosure slide. So I've got my personal disclosures here listed to the left. I did receive a speaker's fee from OPA to be here with all of you this evening. And this program as a whole did receive commercial support from GSK in the form of an unrestricted educational grant. So what we hope to accomplish in the short amount of time that we have together for this third webinar is the following. So by the end of this webinar, you should be able to identify the clinical presentation of acute RSV infection in adults. So keeping in mind, we're focusing on the older adult population for this webinar series. We'll also be able to describe testing options available and how a diagnosis of RSV in adults is established. We will talk about the current standard of care, including nonspecific supportive treatment and the current lack of really available preventative strategies at the moment. And then finally, we'll wrap up with an overview of some of the new research looking at RSV prevention options in older adults, some of the vaccines that are on the horizon, and the future role that hopefully pharmacists will play in vaccination efforts against RSV. So let's dig into the first learning objective, talking about the clinical presentation. So most older adults will present with an upper respiratory tract infection from RSV. We do also see lower respiratory tract disease that tends to be more common in our much older population. So the frequency of that does increase with age, and also among those who live in long-term care facilities have a higher likelihood of lower respiratory tract disease. But most younger, healthier adults will have an upper respiratory tract presentation, which can include some of the more non-specific symptoms like cough, stuffy or runny nose, conjunctivitis, and sometimes sinus and ear involvement. If the infection does make its way into the lower respiratory tract, then that's when we see the potential for bronchitis, pneumonia, exacerbations of any underlying asthma or COPD. Wheezing is also possible because we do see that lack of airway flow going on, as well as potentially shortness of breath as a result. And in particular, the sinus and ear involvement and the wheezing do appear to occur at a higher frequency among RSV infections than other ones, but it's, again, these symptoms are still so nonspecific that it's really hard to distinguish based on presentation alone, unfortunately. So what does the differential assessment look like? So a lot of these symptoms that we just reviewed on the previous slide are consistent across, really multiple viruses that can affect us during the respiratory season. So this chart here kind of really briefly summarizes some of the differences in presentations between cold, influenza, COVID-19, and RSV. And as you can see here, a lot of these symptoms are those nonspecific respiratory virus symptoms that occur with slightly different frequencies across the four, but very similar presentations overall. The most notable difference when we're talking specifically about RSV is that wheezing. So it is much more common in RSV than you can see for cold, influenza, or COVID-19. So that is a bit of a standout symptom, but in our patients that maybe have underlying respiratory illness, that wheezing might be triggered by really any of these. So again, that in itself isn't going to be enough to make that differential. So how do we determine if somebody actually has RSV? Let's talk about the testing options and diagnosis. So since I believe it was October of 2021, there was a program introduced through the Life Labs laboratories here in Ontario, where they do offer molecular PCR testing for community dwelling Ontarians. And this includes a combined detection of COVID-19, influenza, both A and B, and RSV. And it is OHIP covered as a service. The only conditions are that it's only available during the respiratory season, so September through April every year. Outside of those months, it's not available as an OHIP covered service. And there's also a couple of eligibility conditions. So the first is that the person must be symptomatic. So they cannot be eligible for this test if they're, a close contact of somebody, or if they're trying to get COVID-19 testing prior to travel. We saw that be an issue during the earlier phases of the pandemic. So they must be symptomatic and there must be a suspicion of RSV. And the nasopharyngeal swab that is being tested has to be collected by a healthcare professional. It is not something that's done in the lab. So it's not the type of thing where somebody gets a requisition, goes to the lab, and the entire testing process is done at the lab. They need to have the actual swab done by a healthcare professional, and then the sample is then shipped off to the lab. So this is going to be outside the scope of most of us to be doing, but something for us to be aware of, that community dwelling individuals can be eligible for testing if they're symptomatic. There's also some point of care tests that are currently on the market, with a couple of them indicated on the slide here. So the one to the left is the BD Veritor Plus system, and the one on the right is from Abbott with the Binax Now. They have a specific card for RSV. Now, you'll note for both of these that they're indicated only in the pediatric population. So the BD Veritor is indicated for age under 6, and the Abbott for age under 5. And the reason for this, we'll discuss the actual sensitivity and specificity in just a couple slides, but the reason for this is that we have an elevated risk of getting false negative results in older children or in adults, and that's because they have a lot less viral shedding in the upper airway, and that's where the sample is being collected. So even if an older child or adult has RSV, they may not be shedding enough of the virus in the upper airway specifically for it to be caught by the swab. So these tests really for the moment are focusing on the pediatric population. Now, when we talk about people that are presenting to hospitals or are residents of long-term care, they are also eligible for RSV testing. And this is done through a multiplex respiratory virus PCR. So it is a PCR test. It's a nasopharyngeal swab as well. And it detects multiple respiratory viruses in one test. So it's got, para-influenza, influenza A, influenza B, RSV. It's got a whole suite of viruses that it tests against, but at the moment does not include COVID-19. And again, this is that deep nasopharyngeal swab as shown on the image. I'm sure that makes all of us cringe if we've ever had one of those from COVID. It's not a pleasant experience, but it is going to be the most accurate, especially in our older children and adults. Now, in terms of who is eligible for this multiplex PCR, so symptomatic children who present to the emergency department are eligible for it. Older, like adults who are 18 and older, who are symptomatic and hospitalized, can be eligible for the multiplex PCR, as well as residents in institutional settings within a non-outbreak scenario. So, somebody that's in a long-term care facility or other type of institutional setting, as long as they have symptoms, they can receive this testing as well. And then within the setting of an outbreak, so if there is an RSV outbreak in a long-term care facility, for example, there can be up to 4 symptomatic individuals, which can include staff members who can request testing as well. I'm not sure how they came up with the limit of 4, but that's the current eligibility criteria as it is. So for the most part, you need to be symptomatic, and you need to be either a child in the emergency department or an adult who is an inpatient or a resident of an institutional setting. Everybody else who's community dwelling would have to go through the Life Labs program. Now, we talked a little bit earlier about the fact that the point of care tests are really limited to the pediatric populations, and the reason why is indicated on this slide. So we've got sensitivity and specificity. So sensitivity is the ability to detect the infection if the infection is there, and specificity is the ability to differentiate RSV from other respiratory viruses. So you'll see multiplex PCR, as always, PCR is going to be the gold standard for RSV, just like it is for COVID-19, but we do have that rapid antigen test option available to us. The rapid antigen tests have really good specificity, but their sensitivity overall is at around 80%. And I've got this highlighted in red because there's a great distinction between children and adults, as you can see on this slide. So it's got a sensitivity of about 81% in children. They have that higher viral load in the upper respiratory tract. It's only 29% in adults, and that's why we don't see those rapid antigen tests being used in our adult population. So we've talked about what RSV infection can look like. We've talked about how it's diagnosed. Let's talk about how we actually manage RSV in a patient that has it. So overall, most children and adults with RSV require no more than the usual care that we would give to ensure comfort, control of a fever, and adequate fluid intake. So very similar to the other OTC consults that we receive for respiratory type of infections. We'd be looking at bed rest, fluid intake, fever control with an antipyretic agent of some sort. So really that symptomatic control and just waiting for the body to naturally clear it out. That's going to be applicable for most children and adults with RSV, especially the ones that mainly are limited to the upper respiratory tract infection. That said, RSV is not just a cold. especially in our older adult population or in our immunocompromised population, or also in our very, very young children. So our children under 1 as well as the older adult population, we do see the risk of hospitalization and complications go up in those particular age groups. So if we have an older adult presenting to the pharmacy with symptoms that may be consistent with RSV, here's some criteria for when we may want to refer them to get some medical attention. So the first is going to be a high fever, so 40 degrees Celsius or higher, or a fever that's lasting for 3 or more days without breaking. That would be a reason to refer for further evaluation. A severe cough as well, that may indicate that lower respiratory tract involvement. Same thing with wheezing. So as we said before, wheezing is quite common with RSV compared to the other respiratory viruses. In older adults, it's around 35% of people will present with that wheezing. So it can be a pretty clear symptom, but again, in itself is not sufficient for a diagnosis. But if that is occurring, that is showing that we're having problems getting the air in and out of the lungs. Similarly, rapid breathing or difficulty breathing, any evidence of cyanosis to show that oxygen saturation is not where it should be, and if the patient has an underlying chronic disease, so if they have underlying asthma or COPD that's being exacerbated, they would require a referral to have that exacerbation specifically managed. So let's open up a poll question. It's the only poll for this webinar, and this is talking about ribavirin. So ribavirin is an antiviral drug, and what we're asking is, does it have evidence of benefit for treating RSV in older adults? So if you want to indicate what you think, that would be great, and then we'll talk about it right away. Okay, so we've got the results up here. So we have 32% of the audience indicating true and 68% of the audience indicating false. So let's go ahead and talk about what the evidence base really is for ribavirin and whether it has a role in the treatment of RSV. So in terms of therapeutic options, there is no high quality data to support the use of ribavirin. It's available in both an oral form and an inhalation form. The oral form has been affected by shortages for quite a while, but the inhalation form is still available. But there's no evidence to support its use, as well as the use of monoclonal antibodies or corticosteroids in older adults with RSV. The inhaled ribavirin is sometimes, it's indicated for, but very rarely used in our pediatric population, specifically those that are at super high risk of complications. So it is an option for them. It's very expensive. So it's something that's typically done mostly for the higher risk children, but it does not have a role to play in current recommendations for older adults. Now, that said, if the RSV infection has triggered an exacerbation of an existing respiratory condition, so an exacerbation of asthma or an exacerbation of COPD, you treat that exacerbation according to the guidelines for that condition. So the asthma guidelines, they're current as of 2021, and the COPD guidelines are current as of 2019, with both of them provided there. That, of course, can include antibiotics, inhaled corticosteroids, systemic corticosteroids, that type of thing, but you treat the underlying condition. We don't have anything right now to treat the actual RSV virus in particular. So knowing that we have, we've talked about it in previous webinars, the potential complications from RSV infection, and now we know that there's a lack of active antiviral therapy for it. The role of prevention becomes especially important, because right now the only way to not get the complications from RSV is to not get RSV. And so there's a couple different preventative measures that we have available to us. One of them is RSV monoclonal antibodies, which you may have heard about. So palivizumab and nirsevimab are both monoclonal antibodies. The first one is given on a monthly basis to young children. So this is only for kids who are 2 years of age or younger. Mostly the premature, very young tends to be the ones who qualify. But formerly, it had to be given as monthly injections throughout the entire respiratory season. Now, the new agent, the nirsevimab, which is on the market now, is just a one-time injection that provides protection for that entire first RSV season for an infant. So for those of you who are curious, the eligibility criteria are available online. If you were to look up, RSV monoclonal antibody Ontario, the criteria are up there, but it does tend to be premature, underlying risk factors, very high risk younger kids. As we're going to talk about in a moment, we have a number of vaccines for older adults that are in the pipeline, and we also can't can't dismiss the value of non-pharmacologic measures such as hand washing, masking, and trying to really optimize management of those comorbid chronic diseases. If we have better control of the asthma and the COPD before the respiratory season, we're probably going to have less likelihood of it triggering an exacerbation. And as we talked about in previous webinars, the hand washing and masking is because RSV is very highly contagious. It can live on solid surfaces for a day if it's a non-porous surface. We shed the virus for 10 or 11 days, so it's something that's very easily spread. We want to obviously protect those around us from exposure. So now let's talk about what that horizon is looking like in terms of RSV prevention options that we have. That would include vaccines, and that would also include our role as pharmacists in supporting those vaccination efforts. So what is the horizon looking like? The horizon is busy. It's got a lot of activity. We've had a lot of movement in the RSV pipeline over the past couple of years. This is the current status of a number of different vaccines in the pipeline. We have some of them that are still in phase 1, one that's in phase 2, and a couple that are either in phase 3 or have completed phase 3 studies. So as you can see, there's a number of different formulations. We've got virus-like particles, we've got subunit vaccines, there's live attenuated vaccines, mRNA vaccines, so a number of different formulations all targeting RSV, all at different stages in the pipeline. So I would expect quite a lot of movement in this particular area over the next couple of years. So you may have seen news reports in the US in the beginning of May when the first RSV vaccine was approved. This was back on May 3rd, and it was specifically approved for individuals age 60 years of age or older. And then a few weeks later, we saw the approval of a second RSV vaccine indicated for that 60 years of age and older population. So the USA now has 2 vaccines that are both approved by the FDA for the older adult population. And then quite recently, we've had ACIP, which is the American equivalent to NACI, come out with a statement saying that they are in favor of the use of the RSV vaccine in the older adult population. So that's where things are at in the US. And as usual, we tend to be a couple months behind in Canada. So let's talk about the current status of vaccines in Canada. So as of earlier this month, when these slides were finalized, we've got 3 vaccines that are really kind of near the end of that pipeline image that I showed earlier. And I've got them indicated here when we're going to compare and contrast what they look like. So you may remember from the last webinar, we talked about the structure of the RSV virus, and that one of the proteins that sticks out from the surface is the F protein, and it's involved in the attachment of the virus to the host cell and allows for that infection to occur and allows for the further spread to neighboring cells. So that F protein is the target of the vaccines that are available. So the first product that we see here is a recombinant product. It's a subunit vaccine, and it has an adjuvant. And this is the GSK product, and the adjuvant is the same one as what we see in Shingrix. So just keep that in mind. We'll talk about counseling points in a moment, but it does have that adjuvant, which, as you know, adjuvants are specifically designed to really support and promote that immune response to the antigen that it's being presented to. The RSV pre-F vaccine in the middle row is the Pfizer product. It's also a recombinant subunit vaccine, but does not have the adjuvant. And then the bottom row is an mRNA vaccine, which is being produced by Moderna. It does use that mRNA technology similar to what we see with the COVID-19 vaccines. In terms of the antigen content, so the RSV pre-F3, the adjuvanted vaccine, has 120 micrograms of the RSV-A glycoprotein specifically. The recombinant unadjuvanted vaccine has both RSV-A and B with 60 micrograms of each. So we still have 120 micrograms total, but it's split between 2 different subtypes of the RSV virus. And the mRNA is just overall, it's encoding for the pre-F glycoprotein of RSV as well. All of them you'll see are currently being indicated as a single dose intramuscular injection. We can talk during the Q&A period about what it's looking like for long-term protection, whether we're going to have to do boosters and so on. As you'll see, they all are also targeting the older adult population, so the age over 60 years. So as we saw in the US, we've got approval for both the GSK and Pfizer vaccines in that age 60-year population. That's also going to be like the target population for the Moderna vaccine. And Pfizer is also looking at immunization in the second and third trimester of pregnancy with the aim of having that antibody transfer then provide protection to the newborn, especially for the first year of life when they're at elevated risk. In terms of the current status, so we're still awaiting a Health Canada decision on the GSK vaccine, but that has been all submitted. The Pfizer vaccine is at the end of the phase 3 trials and very close to submission as well, and same thing with the Moderna. So those are kind of the three front runners that we can expect to see in the next year, for example, going through the approval and marketing process. So a very common question, of course, is going to be how effective are these vaccines and what is their tolerability looking like? So this slide here summarizes the phase 3 clinical trials that formed the basis for FDA submissions. And this is freely available online. If you want to Google FDA submission for the RSV vaccine, you can see all of that info there. So I just pulled it out from those studies on here. So we look first, the top row, of course, is the adjuvanted vaccine. And so if we look at local and systemic reactions, we do have higher rates of reactions among the vaccine group compared to the placebo group, which is not to be unexpected considering that it is adjuvanted, and we do really see that well-stimulated immune response. So that would be an important counseling point. So the same way that you may counsel patients receiving the adjuvanted shingles vaccine, you may want to tell them that you may feel a little bit fatigued, you may have some pain and tenderness at the injection site, and here are some strategies to manage it. We don't want people being surprised by this. We want to let them know that it's possible, but it's also manageable, and here are some strategies to manage it. We did see, of course, as you would expect, slightly higher rates in the vaccine versus placebo group for the unadjuvanted vaccine. And to my knowledge, I wasn't able to find any data on that yet for the mRNA ones. Serious adverse events, very, very similar across vaccine and placebo groups. We didn't see any statistically significant differences that were a concern. You may read some news reports about Guillain-Barré syndrome cases occurring in some of the phase 3 trials in the US. They are going to be very closely monitored. So we did see some rates in those groups that were slightly higher than what we would tend to see in the general population. So there is a signal there that's going to be monitored further. It's nothing right now that is reading like a major super common concern, but we are going to have the pharmacovigilance ongoing studies looking at that. And then looking at efficacy. So the challenge with interpreting efficacy, and you may have patients saying, well, which one is the most effective? And the challenge is that we don't really have a very consistent definition of RSV. So each of these different products has used different definitions for what they're measuring efficacy against. So we'll see on the top row, we have any RSV, lower respiratory tract disease, that's LRTD, and severe. So they've been classified into those categories. And then for the unadjuvanted vaccine, we have any RSV infection with either 2 symptoms or 3 symptoms or more, and that's how they've defined kind of moderate or severe. And then we see that 2 and 3 symptoms being used again with the mRNA vaccine. So what this means is that it's going to be really hard for us to combine these and to say, oh, the adjuvanted is definitely better than the unadjuvanted or so on, because we're comparing different outcomes. So that's going to make things like meta-analysis very difficult to do. But overall, across the board, we see pretty good efficacy against most of these different definitions for RSV, with especially high effectiveness against more severe infections. So you'll see 94.1 efficacy against severe disease for the adjuvanted vaccine. When it comes to the severe cases with the unadjuvanted, we saw no cases in the placebo group, with 2 cases in the in the placebo group, not in the vaccine group. So we're seeing very high effectiveness there also. And when it comes to local and systemic reactions, I've got the most common ones listed below the chart there in blue. Very common with what we would typically expect to see with an IM injection of a vaccine. So pain, erythema, swelling at the injection site, and then the systemic symptoms, feeling a bit tired, having headaches, sore muscles, maybe a little bit of fever as the immune response is going on. But again, we would counsel that the same way that we do for any other vaccine. And then let's wrap up with our roles. So this might be a a familiar slide for those of you who joined us for previous webinars. And this is just reminding us that we have different roles to play in the immunization world. So we can facilitate vaccination, perhaps by hosting others who can vaccinate. And there's some pharmacies who do bring in a nurse, for example, to cover the surge of the, influenza season. We have the advocacy role, which is educating, empowering, motivating patients, so really encouraging vaccination. And then ultimately, if we're able to, actually giving the injection ourselves. And so for those of you who are on the call, you may be aware that the OCP does have currently an open consultation period available for a proposed expansion in our scope. Part of that proposal means the addition of RSV vaccine to the list of vaccines that we can administer. So if anybody would like to provide feedback on that proposal, you can look it up on the OCP website. And the deadline to do that is going to be mid-August. I believe it's the 12th of August to provide your input on that. So right now, we are in a bit of a gray zone. We don't know what our scope is going to look like with regard to actually immunizing against it ourselves. We don't know what the coverage is going to look like. We don't know what the cost is going to look like, but this is kind of where things are currently at, is that we've got vaccines in the pipeline. We've got the consultation period open for us to potentially administer it. And we just have to keep an eye out for how that's going to change over the next couple months going forward. And that wraps up the actual presentation part of the webinar. These are just the references slides in case you want to dig into them later. Again, I'd like to thank you for joining us today. My email is there if you want to reach out directly, but we're also going to have time available for a Q&A so that you can ask questions today as well.
Yeah, perfect. We do actually have a couple of questions that have come in already, but I do want to encourage the audience, please type your question in the Q&A if you do have any. In the meantime, we'll start with the first question. The first question comes from an anonymous attendee. Could you please explain the difference in RSV attachment on solid versus porous surfaces?
Fabulous question. So, viruses and really any infectious organism, they need a certain degree of moisture to live, and the more porous a surface is, the more able it is to draw out that moisture. So think of like a newspaper or a paper towel or something like that. It tends to suck down that moisture level. It tends to dry out the microbe, and they can't live as long on those surfaces. Hard, non-porous surfaces, so stainless steel, for example, so that would be, doorknobs, washroom, tap handles, that type of thing. They don't suck down that moisture content as effectively, and that does allow for it to live for a longer amount of time. So it's those hard, non-porous surfaces, the ones that a lot of us come into frequent contact with other people. It can live for well into a day on those surfaces, and that leads to some of that transmissibility.
And another question from an anonymous attendee is, how do we counsel patients who are afraid of ADEM? ADEM. I did a quick Google of that. I believe it's acute disseminated encephalomyelitis.
Yes. Okay. Sorry, I wasn't quite.
I wasn't sure of that one either, so I wanted to double check before we got to the question.
Yeah. So this is something that people are becoming a lot more aware of now since COVID happened, right? Because we're seeing the long COVID symptoms really taking on a very similar presentation to that, and we're seeing people who are concerned about, will the vaccine trigger that, or will the virus, exposure to the antigen contribute to that development? Is that a side effect that we can see, and that type of thing? So my understanding is that hasn't been a safety signal detected through the phase 3 trial, so we can be quite reassured by that. But the Guillain-Barré symptoms, I mean, right now, I think we just have to be honest with patients that there's been a slight elevation in number of cases. We don't know yet what that means. We don't know that it's causation, it's association right now, and we're looking into it further to try to disseminate some of that. But, we also have to remember that some of those things can be triggered by the viral infection itself, right? So there's a certain level of risk of that happening from exposure, and then, potentially a risk from vaccination as well. So if somebody is very concerned, if they have a history of Guillain-Barré, they may choose not to be vaccinated until more information comes available. That's just something that we can counsel them on. But right now, there isn't anything in the safety end of things that says it's unsafe because of that. Right now, it's just a hypothesis that's going to be, monitored a little bit more closely going forward.
Our next question comes from Randy. Randy is asking if this is an annual vaccine, would local site reactions, for example, affect subsequent year uptake by individuals?
That's a very good question. So, we've certainly seen that with other vaccines where there's a hesitancy to get subsequent doses if they didn't tolerate the first one very well. We certainly saw that with COVID. We see that with, a number of other vaccines. And so it's possible. I think that's where, the counseling comes, that most of this can be manageable. Let's anticipate and have the tools and strategies on hand that we need to deal with it. And it can be, there's some people who are going to say never again, and there's really no convincing that group of people, unfortunately. But with the others, I think if they're well enough equipped with knowledge about the effectiveness of the vaccine, the risks of RSV, and then balancing that against that local reaction, it would help to support that discussion. And that raises a very good point. I'm sure someone's in the process of typing this question right now asking, is this going to be an annual vaccine, right? And so we have very, very fresh, hot off the press data that was presented in the US to the FDA committees. And that is data that's gone out into 2 RSV seasons. So right now we have, up until now, we had data up until 1 year saying that you have at least 1 season of protection from that single IM dose. Now we have data going into a second full season. So I believe we have mid-season 2 for the Pfizer vaccine and all the way to the end of a season 2 for the GSK vaccine. We're seeing a slight decrease in effectiveness, as we could expect to see over time, but there's still enough the conclusions from both of those is that there's still enough protection for at least 2 seasons. So this is unlikely to be an annual vaccine. The GSK study did study revaccination after a year and didn't find any additional benefit from it. So I don't think we're going to see it being added as an annual vaccine, but after that, we're just going to have to wait and see how the data plays out.
And right now, this is our last question. If there's any more, please type it into the chat. But this question is more of an observation and then a question. But the attendee says they saw on CP24 today that American adults should ask their family doctor before getting the RSV vaccine. Are there any reasons that you can think of why this should be done? Usually for the flu shot, for example, people don't necessarily have to ask their doctor before getting the shot. Or is this just a general precaution?
Yeah, I would think it as being a general precaution. And we also have to keep in mind accessibility and availability of healthcare professionals to do that, right? If we've got 1 in 4, people who has no access to primary care, we don't want that to be a barrier to uptake. So, I think that pharmacists we're well positioned to have these discussions. We have the clinical knowledge, we have the skill, we have the clinical judgment to do it. So I wouldn't support that particular approach. I think that just might be the cautious approach that's kind of taken. Ask your doctor if this might be right for you, kind of thing, rather than it having to be any type of pre-screening to determine if it's going to be safe or effective. So I think it's something that we can definitely do in community pharmacy, make that assessment, have that shared decision-making conversation with the patients. I think that's all well within our ability.
Wonderful. That's great. Thank you so much for answering those questions. We do not have any further questions. So at this time, I will thank everybody for joining us this evening for our 3rd webinar in this series. I'd also like to thank GSK for sponsoring this educational activity. And most of all, I do want to thank Sherilyn for taking all the time to share your experience and knowledge with us over these past 3 webinars. Thank you so much.
Yeah, my pleasure.
Awesome. And with that, I'll thank everybody and have a great night. Take care, everyone. Bye-bye.
Good night.